today's session. We are just kicking off. My name's Claire Alcock. I'm going to be facilitating today's event. Hopefully you're in the right place. This is the third in the series of the Urgent Community Response Learning Collaborative webinars. We had a couple before Christmas. This one is focused today on Community Health Services 2-hour crisis response standards. So looking forward to a really great session, and thanks so much to so many of you for joining today's session. Just a few rules before we kick off. Just to let you know, we are recording today's session. Lots of people aren't necessarily able to join us live today, so we'll be sharing it on the NHS Futures platform, so others who can't come today can view it later. If you have any concerns, please do contact our tech leads. Today I've got Grant and Naheem supporting us, who can be contacted on support@kscopehealth.org.uk. So to make the most of our time today, we're going to be using 4 house rules. So you will have noticed that you're on mute. We've got a very large number of participants joining today, so everybody is on mute, but we're really keen to hear from you. So please do put any questions you have, comments or thoughts in the chat as we go, as well as responding to a couple of the polls that we're going to be putting up today. We're going to review all the feedback and comments after the event, so anything you pop in chat we will be looking at and passing on to the team. Some of you may have problems accessing chat. If you do have problems accessing chat and can't see that, then and do want to ask some questions, then please do. You can submit some questions via my colleague Tom for our panelists today. So you can email him at tom@kscopehealth.org.uk for the upcoming Q&A part of the session. We still do want your views after the meeting, so if you have any thoughts or burning comments you want to share afterwards, please do contact the team at england.agingwell@nhs.net, and they will be happy to receive your contact. If you have any problems today with your technology, our tech leads are, as I said, Grant and Naheem, who can be contacted on support@kscopehealth.org.uk, or drop them a message using the chat function. But if you can't access that, you can always email on that support email address, so please do get in touch. Just some quick advice on notifications. So as I said, you are all muted because we have a very large number of attendees today, so main communication is via chat. The traffic on the chat may be quite busy through the session because we're going to be asking you to submit questions. So you can manage your status notifications if you're on the app by clicking on your profile picture and hovering over the status text. And to silence those chat notifications so you don't get lots of pings, you can select Do Not Disturb. If you're on a browser, you can select settings and then go onto your notification settings and turn off Show Message Preview and turn off Play Sound for notifications. As I've said, we are recording today's session to share it for those who are unable to make it. So any issues or concerns, please contact my colleagues, support@kscopehealth.org.uk. OK, so what are we going to cover today? So as I said, we're going to be carrying on till 1 o'clock. This is the running order, so I'm going to hand over shortly to Kath Evans, who's Deputy Director in the team, who's going to talk through the response standard. Then we'll be hearing a clinical perspective from Dr. Adrian Hayter, who's the National Clinical Director for Community Services and Ageing Well. And then we're delighted to have Dr. Sheila Roden and Maggie Keeble from the British Geriatric Society. So really excited that they are speaking to us today. And then Kath is going to run through some points around the design principles and data. Then we'll have an opportunity for some Q&A with those panelists. Then we've got, we're going to hear from SIT in Norfolk, who's one of the accelerator sites, who's going to give us an operational perspective, which will be great. And then a further opportunity to ask more questions with SIT also on the panel. And then we will be closing, Kath's going to close with some final reflections, and we'll be finishing at 1 o'clock. So just before I hand over to Kath, we'll just kick off today with a chat question about whether you have any technical or administrative distractions. So please pop your response in chat now, starting your message with A1, please. So just hopefully in chat, lots of no's. Amanda has popped a message in chat, which hopefully my tech colleagues can pick up Grant or Naheem. She can't hear anything. Sharon's helpfully said try leaving the meeting and returning again, which is always the advice. It's kind of turn it off, turn it on again advice for Teams. That normally resolves most things. Lots of no's coming through, which is fantastic. Glad to see so many of you. Thank you for responding to that. If there are any issues, then my colleagues Naheem and Grant will pick those up. But that's great. Looks like we've got lots of no's there, which is fantastic. But as I said, you can mute yourself if you need to, using the advice that I provided earlier. So final question before I hand over to Kath. It'd be really great to hear about where you're from. So if you can just pop into chat, responding to starting your response with A2, let us know who you are, give us your name, your role, and which organisation you're from. That would be fantastic. Lots of no's coming through, and Sharon's already got the data flowing through, flowing UCR to CSDS, which is fantastic. Great to hear. So let us know what organisation you're from and your name and your role. That would be fantastic. So delighted to see so many of you joining us today. It's brilliant. Fantastic. Thank you so much. Brilliant to see so many of you joining us today. Thanks for sharing. Please do continue to pop your name and your role and organisation into the chat. But in the meantime, I will hand over to Kath. Kath, over to you.
Hi, great. Thanks ever so much, Claire. So for those that haven't met me before, I'm Kath Evans, Deputy Director in the Ageing Well team in NHS England and Improvement, but leading on the urgent community response. And today I'm going to talk specifically about the 2-hour crisis response. So some of you may remember this was mentioned in the long-term plan, which was several years ago, and we've got a real opportunity this year to make sure we have consistency of coverage of crisis response services and hours of operation for the whole of England by March 2022. And that is a phenomenal opportunity for us to show how fantastic community health services are. Because if you sort of think about A&E, you know, wherever you are in the country, A&Es will broadly deliver the same kind of thing for patients. And that's what we really want for crisis response. No matter where you are in the country, you will get some consistency of response. So it's really important for patients, and Sheila and Maggie will talk a little bit more about the patient perspective. I'm just going to talk a little bit about the operational planning guidance. So the planning guidance was issued, which explained what we needed everybody across England to be doing as a minimum requirement to make sure that patients have access to urgent care needs close to their own homes. And we've pulled this information together based on the support from our 7 accelerator sites. And we have an accelerator site in every region across the country. They typically span an ICS footprint. We've also used evidence data as well to enable us to do this piece of work. We initially started pulling together some guidance on the 2-hour crisis response. It was going to be clinical guidance, but it soon became clear that we needed to expand that to include operational guidance as well. So this is covering operational and clinical guidance. You're getting the higher level today, but there will be a more detailed document going on NHS Futures later on this week. So just in terms of the detail of what we're expecting, minimum requirements, full geographic coverage of 2-hour crisis response across all systems. So that means that if you're in West Yorkshire, because that's where I'm based, if you're in West Yorkshire, whichever town you live in, you should be able to get the same level of service wherever you are in West Yorkshire and wherever you are in London. And that will be as a minimum from 8 till 8, 7 days a week. And we know some services are doing way beyond 8 till 8, and that's fantastic. And we don't want you to stop doing that. because this is a minimal aspiration, and we know that in next year we will have bigger aspirations for crisis response services to be responsive to patients. Also, that those crisis response services will be accessible via 111 and self-referrals, and that's really important. So not relying on people being on somebody's caseload, but being able to pick up the phone and get a response for our community providers, rather than having to end up in A&E or going to the GP to be triaged to be sent to the to crisis response, or actually not getting to crisis response services. And what is absolutely essential is to make sure that crisis response services are submitting to the community services data set. It's a mandatory legal requirement. And if you don't submit to your crisis response into the community services data set, we don't know it's happening. We can't demonstrate that nationally, but also you can't use that information to benchmark yourselves against other services. Next slide, please, Claire. So I've mentioned that we've got some guidance, and we'll be talking through that today, and that will be available on the Futures platform. There's the key areas in the guidance. I'm not going to read them out, but those are the kinds of things that are in the guidance for you to go into and have a look and then apply in your local team. What we are doing is making sure this is about the what, not the how. So how you operationalise that and do that from a clinical perspective is down to you, but what we're saying is this is what needs to happen all across the country. Next slide, please. So I think I've probably covered most of this. So I think the only thing I'd like to add to this is about using capacity and demand modelling to prepare for your extended hours. So we know, we've said 8 till 8, 7 days a week. There's some clinical requirements which you'll need to start to blend into the work you're already doing, but then start to model that about. So what does that mean in future years? How do you know when the most urgent care is needed? Is it at 8 in the morning, or actually is it at 10 o'clock at night? Do your services need to go beyond 8 till 8? And what kind of staffing will you need to do that? And what percentage achievement are you getting in your services? So is it good enough that 45% of your patients don't get a response in 2 hours when you've deemed that should happen? So think about those things in terms of your planning for the future. So the key message here is it's not stopping with what we've put in today. It will develop, and really welcome your feedback on that. The other thing we want you to do is make sure that you're working with our urgent care providers, so 111, 999, etc., so that if an ambulance turns up to a patient in their own home and that patient doesn't need to be admitted but can't be left safely without a crisis response, then we really need you as systems to respond to that. And so making sure your services are actually profiled on the directory of service so that they can be found through 111. And we've got a lady in our team, Sarah, who is working on that to make sure we can do that more effectively. So I'm going to stop there and move on, pass over to, I think it's Adrian, in fact.
Yeah, no, I'm just pass over. Thanks, Kath. That was a really great overview. Just to say, if colleagues are having problems, so we've just shared the slides on the chat. So if you are having any problems, you can access them there. If you cannot access the chat, or I think we've got a large volume of people joining today, which is fantastic. But I think Teams can sometimes struggle to cope with lots of people joining at the same time. So if you are having any problems and wish to submit any questions, please do contact my colleague Tom at kscopehealth.org.uk. Tom, if you can pop your email address in the chat now. If you're having any problems with any technical problems, please do contact my colleagues who are available to support you. You can either pop a message in the chat if you're having problems and they'll pick it up there, or you can email support@kscopehealth.org.uk. If you are having problems with pinging, please do. We've got a lot of people using the chat today, so you need to turn off your notifications. So if you're on the app, you need to just hover over your face in the top right-hand corner and change it to Do Not Disturb. So I suggest you do that because we are using quite a lot of chat. Thank you, Grant, who's just popped those instructions into the chat now. But if you can't access the chat, that's not going to help you. So please do pop notifications on. Thank you. I'll just hand over to Adrian now, but just as a reminder as well, please do pop any questions you've got in the chat box, or email my colleague Tom, and we'll be picking those up as part of the Q&A session coming up. Adrian, over to you.
Great. Thank you, Claire, and thanks, Kath, for that introduction. Adrian Hayter, I'm a GP and the National Clinical Director for Older People and Integrated Person-Centred Care, NHS England and Improvement. I'm really excited. This is a world standard, which is world first, really, for a standard which is applying to our residents, our population who are living in the community. And this is taken some time to be able to put into the detail that we have and launch today, and is part of, as Kath said, the long-term plan and the ambitions which came out of the long-term plan. So thanks to my predecessor, Martin Vernon, who supported some of that work in getting it into the long-term plan. And this will mean a lot for patients in terms of giving that kind of standard, and for us working in the community together to be able to deliver it. So I'm going to introduce two of my colleagues. First of all, Dr. Sheila O'Riordan, who's a geriatrician who works in Kent, who's also the chair of the BGS Community Geriatric Special Interest Committee. And then also Maggie Keeble, who's a GP like myself, who also works within the Geri GP group at BGS, and who's a GP in Worcestershire, and has got a wealth of experience around working in the community. So we've got two specialists who are really kind of linked into this work, and I'm going to hand over first of all to Maggie, and then over to Sheila to give us a little bit more around their experience and their thoughts around this standard.
Thanks, Adrian, and thanks, Kath, for your introduction. Just to think about this in terms of the benefits for the patients, it's always good to go back to basis and just think about actually why we're trying to do this. So if we could go on to the next slide, please. That's lovely. So the building on what Kath said, the purpose of this is to develop a standard offer. We know that there's considerable variation across the country into what options there are for people when they're in a crisis situation. Some areas have really quite robust hospital at home services, virtual ward teams, and are delivering this kind of offer already. And in other areas, there is just not that service at all. So this is trying to achieve something that will be standard, and it will not depend on where you live or the cohort or the circumstances in which you live. Some of the services that are now available actually exclude certain people, such as care home residents. So the offer here would be for everybody, dependent on their needs. The vision will be that this will be an integrated support system, so that there will be an appropriate response to develop an acute management plan, and to put plans and support in quickly in a timely manner. It will mean that people will be able to talk about what they want to happen, and will be able to adapt and adopt according to actually what's appropriate for their situation. That because of the way that this will be structured, they will be seen as supported by an integrated service, and they will not be being passed off to different locations and having to start to tell their story on each occasion with each interface of care. The other really positive element that we have to, I think, publicise in more detail is that actually hospital can be a dangerous place for older people, and that by not going to hospital, then we're reducing the risks of hospital-acquired functional decline, of hospital-acquired infections, and the risks of other conditions such as delirium, which we know the risks are higher if somebody is removed from their place of care. In terms of the benefits for services, our service providers and their teams, I think that the the benefit of what we're getting is that there will be a clear expectation, that there will be clear standards in order to deliver. It sets out the common conditions. Sheila will talk about that in a bit more detail. It sets out the appropriate assessment tools, and it really describes how we will be supporting complex decision making by experienced clinicians in a timely manner. So it will really encourage investment in community services and increase their viability and the impact. Next slide, please. In terms of the criteria, for those of us working in services supporting old people, particularly, that we it seems very obvious when this will be appropriate, but it needs to be specified that this will be appropriate for situations where there's been a sudden deterioration in health and or well-being dependent on their social situation. It may be that this is an entirely new condition or that it's an exacerbation of a chronic condition. It will be typified by a sudden deterioration in functioning. Now, it may be that a rapid response is appropriate because it's a relatively early situation where somebody doesn't need to be in hospital, but that actually if they don't have a timely response, their condition would deteriorate such that they would be at risk of hospital. The other situation where it's really important that we offer a nuanced approach is where there's been an agreement that the person really does not want to go to hospital, that actually this will be part of a pre-existing agreement or a discussion that's held in the home at the time of the assessment, whereby there is an acceptance that someone's priority may be for support in the home, and that actually they would rather prioritise comfort over survival. And that's really important, that we're enabling those conversations, that we enable that variation in offer, not dependent on the condition in front of us, but independent on the person and their situation. The other situation where this may come into play is if there's a social crisis, such that if there's a breakdown of particularly informal carers, where if you've got somebody living with significant frailty or dementia, that it's the partner, the spouse often, that takes that caring role, and for some reason they're no longer available. So next slide, please. And again, this really just goes into this in more detail. Although the age groups and the people we're likely to be supporting are likely to be those people living with frailty, obviously this would be open to anyone over 18, so it's not frailty exclusive. They would be living in their own home or in a residential setting, that they need a crisis response quickly. Living with dementia, obviously being able to liaise with older adults' mental health, really important. There is an exclusion there around being acutely unwell, but we've already said that actually if there's a plan that somebody, even if they are acutely unwell and accept the risks, then actually that it's appropriate for them to be supported. So any of these exclusions may well be trumped by an advanced treatment plan. So I'm going to hand over now to my colleague Sheila, who is already working in a hospital at home service. Thank you, Sheila. Can't hear you, Sheila. I don't know if you're on mute.
I'm not anymore. So thank you, Maggie, and thanks everybody. In front of you is a list of possible inclusions and possible things that might happen that might mean that you could be called for this. But I'm going to give you a sort of a case history just to, which might, I think, give an example. So if you imagine John, who's 89, he has mild dementia, he lives with his wife, and he's been more sleepy for the last couple of days. And this morning he had a fall. I think that John, I think he needs a natural assessment. You know, has he injured himself? What was the cause of the fall? What is the cause of the delirium? The more sleepy part of that is almost certainly a delirium. And I think he needs an assessment for that. We might need to do some point of care testing to see if there's any evidence of infection or an electrolyte abnormality, and then he probably needs some treatments, such as a medication review. Maybe it's constipation and he needs some laxatives, or maybe it's an infection and he might need some antibiotics. He might need some equipment because actually he's a little bit, he's less mobile than he normally is, and he is having trouble getting out of his chair, for instance, and he might need care to support his wife while he gets over this acute event. And if that doesn't need to happen in 2 hours, then that doesn't trigger this response. But if that does need to happen within 2 hours, otherwise John will go to hospital, then we should be doing it in 2 hours. It is perfectly reasonable for us to provide this care within 2 hours if it's necessary. And it's very clear to me that you don't have to do it in that timescale if it's not essential. I think the other things on this list were urgent catheter care, urgent support for diabetes. There are lots of people who go to hospital because their sugars are too high or they've got a hypoglycemic event, and it's much better to sort that out at home than go to hospital. And then Maggie's already mentioned about unpaid carers, but that is a very common reason why people go to hospital completely and utterly inappropriately. Could I have the next slide, please, just Claire? So there's a whole load of development that needs to go on behind this. And I think there are so many people who are already providing something very similar to this. So there are lots of places that provide some form of urgent support, but maybe don't have exactly the right crowd around them to support it. And I think one of the key things of this is advanced clinical practice. So I mentioned earlier that for John, we will need to be able to do an assessment that leads to a diagnosis. And that is something that people who have been trained in advanced practice will be able to do, no matter what their background. Obviously, there are others, and you may want to include GPs or other doctors in your team to provide that as well. There's no reason why we can't link with the acute hospital teams, such as the geriatricians that work there. And then there's other people like prescribers and hot clinics and people that you can link to. There's a whole world of training behind this, and there's a sort of tiers of training in the context of frailty, which I think would be really useful for us to look at. And I think that somebody in your team will need level 3, but not everybody will, and others might need level 1 and level 2. I mentioned before about point of care testing, but what we can't have is a situation where older people are being patched up, but we're not actually making the diagnosis. And point of care testing has moved on so quickly and is ever so easy to do. We use 2 different types of machines, and we can get, electrolytes, hemoglobin, CRP, and quite a few other bits and bobs as well, and it really helps you make a decision about what's the most appropriate treatment for that person, and I think that is an essential part of this. And then I think going forward, we need to identify who are the people we're going to be looking after, and what is going to be the needs for them. Care is obviously going to be very important. There's no point, doing the 2-hour crisis response and then having nothing to offer in the plan that you've made. So it's got to link to lots of other things, and it's got to link within a team that isn't doing the 2-hour response but can do the 2-hour response. I think that's been my way of looking at it. So back to you, Claire, or in fact.
Thank you. No, that's fine. Back to me. I'm just going to hand over to Kath. Thanks to those of you who've popped questions in chat. We've got a very large amount of people joining today, which is fantastic news, but it is making Teams quite slow, I think. So if you are having any problems, my colleagues have popped a few messages in chat. But if you are having any problems and can't access the chat for any reason, or having audio problems, please get in touch with my colleagues who are providing tech support. You can get in contact with them at support@kscopehealth.org.uk. I'll just ask them to pop their contact details in chat again. If you can't access the chat, you can email any questions for the panel, which is coming up, to tom@kscopehealth.org.uk. So please do continue to pop questions in. And we'll be moving on to the Q&A panel after we hear from Kath. Kath, over to you.
Thanks, everybody. So I'm just going to whistle stop tour through the design principles. So we've got 7 written here, and there's a couple more on the next slide. So the key things about the crisis response service is, and we've built these together based on the questions we've had over the past year on the crisis response, but also on what we've learned from the accelerator site. So should be a commissioned service and coordinated through a local single point of access. And if you're as long in the tooth as I have, you will hear of organisations that have multiple single points of access. We don't want patients to have to ring lots of different services or lots of single points of access to get to the right service. So it should be a no wrong door approach. So whether you're on a caseload or not on somebody's caseload, you should get a response. Be centrally coordinated, so if it is a single point of access, that they may refer into one team that does all of the crisis response, or multiple teams through a range of professionals. And we need to make sure that those professionals work in an interdisciplinary way, so that they take on the traditional roles of others. So, for example, therapists have an absolute really important element to crisis response. But they could do some of the work that traditionally would be done by a community nurse, as an example. We need to make sure we're reducing health inequalities, and that has been really shown throughout the global pandemic about health inequalities in local populations. Making sure we've got shared approaches with same-day emergency care so they get access to acute diagnostics. We know some of that will take time to build, but start to think about that now. Make sure we're providing holistic and personalised, so it's not a series of people traipsing through people's doors and asking the same questions that the other team has asked. So something about the trusted assessor principles. I'm mentioning CSDS, the Community Service Data Set. I'm not going to mention that anymore. Next slide, please. And Sheila's mentioned this around, so some care doesn't need to be delivered in 2 hours. And remember, the 2-hour crisis response is about avoiding a hospital admission, or where somebody's clinical need or social need will deteriorate so much that actually we're putting them at harm. So it's not about everybody. You may respond in 2 hours, but it might not be needed in 2 hours. So this is about, it's really difficult to get your head around, but some of this is about a standard and some of this is about a service. So if you're providing a service that happens to respond in 2 hours, that's fine, carry on, submit it to CSDS, but don't worry about hitting a standard. If it's a crisis response service and you absolutely should be responding in the 2 hours, then that's where we need you to be collecting that in that way. And to use the technical guidance which has previously been published last year, and we've got a link to that at the end. The vast majority will be delivered through face-to-face, although there are scenarios, and particularly like, for example, with care homes, where you will respond in a remote way. But we need to make sure that that remote way isn't hitting the target and missing the point by ringing somebody and saying, oh yeah, we've assessed you, that's fine, we'll see you in 4 or 5 hours. If that patient genuinely needs a response in 2 hours and they need a face-to-face, that's what they should get. So please don't try and play the system. We want this to be right for patients. I've mentioned about duplication of assessments, and then just a quick message. There is funding so it's, in effect, there's 273 million which has gone out to systems to enable you to fund some crisis response as well as other services in community health services. So there is funding out there. So if you need to expand your services, that funding is there. Next slide, please. I've talked about CSDS. Go to the guidance, read it, use it. That's it.
Fab, thank you. Thanks so much, Kath. So that's a really good coverage of all of the kind of key points there. So thanks so much to all our speakers so far. We've got quite a few questions that are coming in, so do feel free to continue to put those in. We're just going to have an opportunity for some questions now. And then we're going to hear from Sit in Norfolk and an opportunity for some further questions. If we don't get to any questions today, we will pick them up off the chat and we'll be sharing them with the team. So nothing will be lost if you pop it in the chat today. If you are still having any problems technically, then feel free to get in touch with my colleagues either on the chat or by emailing support@kscopehealth.org.uk. I'm just going to kick off with some questions, if that's okay. Kath, I was just going to come to you first. Colleagues just popped in about sharing the slide deck. Tom, if you can share the slide deck back on chat again, that would be fantastic. If anyone's missing any of this today, we are recording it, so we will be sharing it after the meeting. Kath, just a quick question on two things. One is just a reiteration of when will the guidance be published, and also a question that's come in around operating hours being mentioned about operating hours being from 8 till 8. Does that mean that cut-off time for last referral is 6 p.m?
Okay, thank you. So there will be a slide deck, draft slide deck published, and it'll go on in the next 2 or 3 days on futures. And then the Word document is going through the approvals process in NHS England. So that will take a bit longer, but use the slide deck in the interim. In terms of the cut-off from 8 till 8, is there a cut-off time? We're not saying that. That is how you need to do that. But bear in mind what your demand is. Now, for some services, they may already be doing 8 till 8, but feel there is greater demand between 6 o'clock and 8 o'clock in the evening and may expand their services to 10 o'clock. So remember, this is a minimum. It's not the only way of doing it. So it's, you know, if you feel there is greater demand, you can do that. It's within your gift.
Brilliant, thank you. And thanks to colleagues. Some colleagues are popping some questions, and Sarah from the team is also responding some questions in chat. So I won't pick up on those, but thank you for those that are coming in. Question that we've had, which I think there's been a bit of conversation in chat actually about it, but Maggie, I don't know if you've got some thoughts around the point around questioning around decompensation and frailty. Be good for you to pick that up.
Yeah, thanks, Claire. I think it's fairly straightforward because, I mean, the main feature of someone living with frailty is that they're vulnerable to sudden deterioration. So that's really all it means. That sudden change could be due to, as Sheila has said, it could be infection, it could be electrolyte imbalance, it could be an environmental change. Any of the causes may result in a fall or delirium or poor mobility, reduced continence, and it may be a trigger that it's been medication. So those classic so-called geriatric giants that we recognise, that's what we are talking about when we talk about decompensation in frailty. It's similar to I think maybe we should talk about an exacerbation of frailty, much like we would with an exacerbation of COPD. It's a chronic condition with acute exacerbations.
Thank you, really helpful clarification. Kath, a couple further ones probably for you. Question around different versions of the referrer list, and a question about is self-referral a requirement for this year? And then the second question was around capacity and demand templates, about whether there are any templates that will be required as part of the planning phase.
Okay, so in terms of self-referrals, one of the reasons why we've asked people to be able to access crisis response through 111, because that enables self-referrals. We're not being explicit on how those self-referrals need to happen this year, but make sure that you're available through 111. So, and then the question about capacity and demand, we've not asked you to explain that in the we've not asked you to do the numbers explicitly in the planning template. We'd like you to write your assumptions in the narrative. So there is two templates. There's a numbers template and there's a narrative template. If you want to explain your how you've worked it out in very high level, please put that in the narrative. But in terms of helping you do your demand and capacity, there is a team, and David's written it in the chat box already. There's a team in NHS England that have got a tool to support you with this. So we're advising people to go to that team and have a look at the details on there.
Fab. Thanks to colleagues within the UCR team who are responding to the questions on chat. That's super helpful because we've got lots coming through. It's brilliant to see actually how many people are actually sharing contact details on here, and just people calling out for a contact in Bob, and people putting those contacts up. So really great opportunity for people to share contact details. We've got a few more questions, but I'm going to move on to hear from Sit, and then we'll come back to those questions afterwards. So again, as Sit's talking through her presentation, if you have any more questions for her or for our other panelists, we'll come back to that afterwards. But Sit, in the meantime, I'm just going to move on. I'll move back to the poll later, but I'm going to come to you.
Thank you. Norfolk is known as Nelson County, from Kings Lynn to Lowestoft and Cromer to Thetford. We live and work in a diverse 2,900 square mile landscape of beautiful countryside, a major city, a picturesque market town, the Bode National Park, and more than 100 miles of nationally celebrated coastal line, serving a population of 1.1 million people, with 53% of whom are rural. Norfolk and Waveney is one of the 7 accelerator sites aiming to shape the urgent community response national standard. Within that, we are aiming to implement the 2-hour urgent community response national requirements at scale by 1st of October this year, with 80 to 90% threshold. We will be demonstrating the benefits of implementing the urgent community response standard for service users, the workforce and the system by avoiding unnecessary hospital admissions and preventing the individuals reaching a crisis point. We are developing and sharing tools, guidance, resources and learning at a local and national level. Due to the geographic challenges in Norfolk and Waveney, innovative solutions have been implemented, such as WebFleet, a system which gets the nearest healthcare professional to the service user. WebFleet also provides data that shows clinicians' actual response time, whether it's due to travel or failure to respond in a timely manner. As this initiative was a success with the night service, we are currently piloting it with the day service in an urban area, especially with the level of engagement received from staff. We reviewed our service model in relation to admission avoidance, ED attendance data, as well as working collaboratively with different stakeholders to understand community service assets and demands. As a result, we agreed to enhance our admission avoidance service by changing the response time from 4 hours to 2-hour urgent community response. We are also integrating some services, including social care, as a way of managing demands. And as a result of that, we are able to deliver a 24/7 service. We are working closely with NHS 111 and managed to profile the community service on DOS, the Directory of Service, as part of increasing referral rates by avoiding some conditions being diverted to 999 or ED, for example, falls with no apparent injuries. As part of the integrated health and social care, integrated data sharing has been a challenge, but close working relationships are helping us to gradually co-produce system sharing. Community service data set, sorry, you've been hearing this quite a lot today, CSDS, is designed to monitor the delivery of the 2-hour urgent community response. Improving the quality of data require ongoing record level review to avoid variations and meeting the requirements. The next slide, please, Claire. The 2-hour urgent community response has shown benefits to individuals and the organization. From an individual perspective, improving outcome by easing their pain, suffering, and maximizing their dignity. Preventing unnecessary hospital admissions by treating them in their own home or environment. Improving individual carers and loved one experience by improving their access time. And from the organization perspective, it's around providing quadruple aim to guide the transformation of urgent community response. Thank you.
Fab, thanks, That was brilliant to hear. Got quite a few more questions coming through, so I will just take the opportunity now to ask a few more of our panel. Please do continue. If you pop any questions in that we don't get to, we will pick them up and share them back with the team and look at if we can find a way to respond on futures. So we will pick up questions that we haven't had. First couple of questions around different. So one colleague put in a question around that they thought this sounded quite medical, assessment and diagnosis based, was asking about where the therapy model was, and another person had responded around the importance of AHPs in taking a multi-skilled approach. I don't know whether Kath or Adrian wanted to pick that one up.
Yeah, I can pick that up. I mean, I think this is very much, and I think there was a question a bit further down, Claire, in terms of also the role of social care and kind of supporting kind of the whole individual. And if you like that, this is the unique thing that we have within the community, the ability to use that kind of whole team, that integrated approach that we've been talking about. So I would say that we've been probably reflecting a bit of a medicalised, more NHSE kind of perspective on this webinar. However, really, I think it's worth emphasising that integrated care decision-making approach, which involves kind of a range of professionals, therapists, and care in the community, which should join up to deliver the best service for that individual in a joined up way. And I think that's the unique thing that we can provide in the community by having the right teams available with the right constituents to that team at the right time. Kath, is there anything else you wanted to add to that?
No, I think you've summed that up nicely, and we have got Kate Jackson, who's our AHP lead, who's listening but not quite yet on the panel, so she could be brought onto the panel if we want to ask some more questions for her. But I think the key point is it is about the holistic needs of the patient. And I suppose what I didn't mention was how we ended up starting down looking at sort of like clinical definitions was we wanted services to be on the directory of services, but the directory of services is a very medical approach, so there is diagnosis. So we started to sort of say, well, what would those things be? So we talked about falls, and then we sort of, well, would it be a blocked catheter? Well, yeah, that's quite clinical. And we still go right back, you know, and whenever you're designing these services, go right back to what is the patient need and really focus on that need. So it might be any of those things that we've described, but it may be nothing like that, and it's way more complex than that. So it's about the patient needs. So those patients' needs will need nursing, they will need therapy, they will need medical, they will need social care, they will need the voluntary care sector in different amounts of support depending on that patient's need. So nobody is excluded from this.
And people aren't conditions; they're people, and we, as Kath said, we're focusing on their needs, and also just in terms of the rehabilitation and the professionals kind of supporting that rehabilitation. This is not just about the 2-hour crisis response; it's also about the 2-day, you know, in terms of supporting people as they get discharged from hospital and getting that expertise in terms of those professionals who have the expertise to support that individual to remain well in the community and get back some of that functional ability when they've left hospital. So the ethos of UCR is not just about the 2-hour, but it's also around the role of our professionals working to be able to support people on discharge as well.
Thanks both, and quite a few comments coming through about including the voluntary and community sector in this as well, and not just statutory bodies. And that actually they've got a huge role in that. So lots of nodding there as well. So thank you. That's great. Just conscious of time, I'm just going to ask a couple more questions that we have. One question which Kath, I might come to you on. Interested that previous standard state uni disciplines such as district nurses would not be included, but there was an example regarding catheter and diabetes. In the main, this support is delivered by this discipline and staffing group. Comments, please. I don't know if you can pick that one up.
Yeah, so this is, we've listened, so we started off very much following the NICE guidance around a multidisciplinary team. And for those of you who've been around intermediate care teams for a long time would recognise that it's a team that is co-located and do sort of like wouldn't have that unidisciplinary approach. What we've found as we've talked to systems and we've worked with the accelerator sites, there isn't quite such a pure model. And what some areas have been doing and doing very successfully is where the referrals come in through that single point of access and go out to teams that are ready and waiting for those crisis response. So City's nodding, and it's very much the model they have in Norfolk. So for example, and I'm a district nurse by background, so I really get this. So services may well provide a core service model to provide crisis response services, and they could be enhanced to become more disciplinary to respond in a crisis. But it's about making sure they cover the holistic pathway. So there's no reason why district nurses can't continue to do, blocked catheters, etc., as part of their planned work and reactive work. In other areas, that might be accessed through a single point of access where they send those referrals out specifically to those teams that's part of that crisis response. It's not a pure answer, I get that, and don't get hung up on it. The really important thing is that patients get that response in the crisis. So if you have your district nurses are doing what district nursing used to be like when I was there, which is you had your caseload, you had your patients that you did your blocked catheters to, and you had your end of life care and your wound care, and it was all done as one team. That's fine, you can carry on doing that. But if you have a crisis response team that is going to pick up some of those catheters to enable the district nurses to do more planned care, that's absolutely fine as well. We're not dictating on how to do this, we're saying what. So we're trying to make it flexible. Obviously, this is the first time we've set a national standard and we're learning along with you. And so any feedback is really helpful. And we will use the community services data set to be able to see the difference across the country. So is one area got 10 referrals for crisis response and another has got 20,000 for the same kind of population? We'd want to know what the difference is and learn together about that.
Brilliant, thanks, Kath. Sit, there's been a lot of love from what you said coming through the chat, which is brilliant to say, and also brilliant to see so many people sharing experience and responding to people's questions and sharing their email addresses, which is kind of part of what this is all about, to really get as many people together and really share that experience. But Sit, I just before we just move on, I just wanted to give you an opportunity to respond or build on anything that Kath said from your kind of experience in Norfolk before we move on.
Yeah, sure. So part of the integration we're doing is we're trying to integrate, we're in the process of integrating social care into 111, because what we want to do is improve that response time within 2 hours rather than 2 hours. And we are involving people like Age UK into those process. And at the same time, we're not just looking at the crisis response, but we're going beyond that. So the other two key things we're doing is working with care homes and providing them with the same care, as well as working with anticipatory care. So hopefully we're preventing those individuals coming back into having another crisis. So we're trying to work with them to prevent them having a second one.
Brilliant, thank you. We may have a time for a couple or a question or two more, but I just wanted to ask my colleague Tom to pop up. We've got a couple of polls that we wanted to ask people, and then we'll just take one or two more questions, and then I'll move to Kath to close. So first poll question, which my colleague Tom has just shared on, which should have just popped up and it's on the chat now, is: having heard more about the content of the guidance, are you clear on the 2-hour standard delivery expectations by 2022? Opportunity to say you're very clear, fairly clear, unsure, or still not clear. So please do vote now. That would be brilliant. Some people are putting very clear in the chat, which is fantastic. Do pop in the chat if you want to, or vote. Hopefully a box will have just popped up. Opportunity to say very clear, fairly clear, unsure, or still not clear. Lots of very clears actually coming through on the chat. So again, happy to receive responses either way. Just giving you a chance. While we're just doing that, Kath, one of the questions that came up was about the funding and whether it was recurrent and when it was available from.
Yeah, so the funding is there this year, so it's already out there. And there is a provision in the long-term plan for the funding to continue next year as well. So as far as we are aware, in terms of funding, that is going to continue. You know, you can have confidence in that. And the other thing to bear in mind is there was a commitment in the long-term plan for an uplift of £4.5 billion. Funding guarantee for community health services and primary care. So it's part of that funding guarantee as well. So we would expect to see investment all across the board in community health services, and that funding is there.
Brilliant, thank you. I'll ask Tom just to close that poll now and show the results. That would be really, really helpful. And we'll hopefully be able to see what people are voting. Lots of people putting very clear into the chat, so that's brilliant. And then we'll just pop up. Oh, so there we go. We've got 32% saying very clear, 59 fairly clear, and a smaller number of 7 and 2% unsure and still not clear. Please do pop in the chat if you want to expand on that. Just before we move over to Kath, Tom, can you just put the next poll into the system? That would be great. And while Tom does that, please do vote. If you, Tom's just going to load that poll now. Thank you, Tom. So this one is thinking about your area on a scale of 1 to 5. How confident are you on being able to deliver the 2-hour standard by 2022? So same approach. If you would just either pop in the chat or vote there from not confident at all to extremely confident, that would be fantastic. If you just submit your responses now. I'm just going to hand over to Kath shortly to talk about kind of final reflections and next steps. One of the questions that's come through, Kath, is will you be doing a session for the 2DD, which I'm assuming is the 2-day standard, or maybe it's something different?
Yeah, let's assume it's a 2-day standard. So we're not focusing on this this year because it's not in the planning guidance. That doesn't mean to say you shouldn't carry on doing 2-day reablement, but our focus this year at this very moment in time is about the 2-hour because of what's in the planning guidance. So that's that. Do you want me to do my reflections now as well, Claire?
Yes, sure. I will just ask Tom to just whilst Kath is doing that, just to close that for that poll shortly. So just give it another 30 seconds and then close and show the results. Helen's just asking, how do we access the recorded version? We'll be sharing that afterwards, so we'll send that in a follow-up email. And thanks, Tom, for sharing that. Again, please do pop things into chat if you would like, but we've got kind of moderately confident 40%, very confident 31, and smaller number being not confident at all and slightly confident. So that's reassuring. Any issues you have in terms of lack of confidence, please do pop them in the chat. And we'll be able to follow those up with you. But yes, I'm just going to hand over to Kath for last minute final reflections and next steps. Thanks, Kath.
Yeah, thanks very much. This has been great for us to see all your questions because it gives us a good indication of what other questions we need to be answering. And there was a great question about, you know, can we put the answers to the questions on the Futures platform, which we will do, and it will help us develop moving forward. We're all in this together. We're all in this to make the best for patients moving forward all across the country. So as far as I'm concerned, there's no daft question. We may not always have the answer, and some of it we may need to think through a bit more. And we urge you to work with us and be kind to us because we're all trying to do the same thing. So really appreciate how hard it is, and I really appreciate the efforts you're going through to work with us on this. So thank you. And you know, as well as sort of like the support from the accelerator sites to enable us to have got to this position today to be able to share this guidance with you. I'd just like to thank our fellow presenters as well. We will, which help bring it alive, because I think, you know, it's really important that you see that it's people like yourselves that are able to implement this at scale and pace. We are looking at potentially having a clinical reference group, so if anybody is interested in that, just put your name in the name and contact details in the chat box. You will be able to see, I don't think you can see it underneath the slide, but underneath the slide is about how you can access further resource. So you have got, the regions can help you. You can email us at the Aging Well email address. There's a Futures platform. You can follow us on Twitter, and that will enable you to make contact with us. But just please don't hesitate to drop us emails, and we'll follow up with you.
Brilliant. Thanks, Kath. Tom, if you can just pop the final feedback form into chat. If I know lots of you have to dash off, but if you do have a chance to just give us answer a couple of questions on feedback, Tom's just popping that in the chat now. But it's 1 o'clock, and I said we would finish at 1 o'clock. So thanks so much for all your time today. Really, really appreciate it. It's been a really valuable session, and we'll be taking all of that chat away and taking a look at it and responding. Thank you. Goodbye.